Hi, I'm Rob Grant. Today I'll be discussing our study, Prevalence of Mutations in Cancer Predisposition Genes in Patients with Pancreatic Cancer. Our lab is particularly interested in pancreatic cancers that are caused by inherited mutations in the BRCA1 and BRCA2 genes. These genes are famous for causing breast and ovarian cancer, but also increase the risk of pancreatic cancer by up to 7 times that of the general population. Identifying patients with BRCA mutations can have important benefits. Relatives should undergo genetic screening, and carriers of mutations may benefit from interventions like bilateral mastectomies and salpingo-oophorectomies. Also, emerging evidence suggests that pancreatic cancers caused by BRCA mutations have a distinct genomic landscape, prognosis, and response to therapy. Clinical trials are currently underway investigating agents that specifically exploit the defective DNA repair pathways in BRCA-deficient pancreatic cancers. We don't know how much pancreatic cancer is caused by mutations in the BRCA genes, because studies to date have focused on cohorts selected for family history or ethnicity rather than population-based cohorts. Other genetic syndromes significantly increase the risk of pancreatic cancer. These include Lynch Syndrome, familial atypical multiple mole melanoma syndrome, familial adenomatous polyposis, hereditary pancreatitis, Peutz-Jeghers syndrome, and Li-Fraumeni syndrome. The benefits of identifying carriers of mutations that cause these syndromes is similar to that of the BRCA genes. The goal of our study was to define how much pancreatic cancer is caused by mutations in known predisposition genes. We sequenced 13 genes that cause the syndromes I just described in a population-based cohort of pancreatic cancer patients. We wanted to detect at least one mutation in any gene mutated in over 1% of pancreatic cancer. To achieve this with adequate power, we selected 290 of 708 probands with pancreatic cancer from the Ontario Pancreas Cancer Study. The OPCS is a population-based cohort that recruits all consenting participants with a pathological diagnosis of pancreatic cancer in the province of Ontario, Canada. To maximize the precision of our estimate of the BRCA mutation rate, we randomly selected patients from 3 strata based on family history of BRCA-associated cancers. Lymphocyte DNA from all 290 probands underwent targeted next-generation sequencing. Our bioinformatic pipeline detected genetic variants in the pancreatic cancer predisposition genes. Rare, non-synonymous variants were classified as either pathogenic, of unknown significance, or benign, based on their impact on the protein and publicly available databases. Each position in the targeted genes was covered by an average of 354 sequencing reads. Most rare non-synonymous variants were of unknown significance. On average, each proband carried 1.2 variants of unknown significance. Longer genes had more variants of unknown significance, supporting a more benign role for these variants. We detected 11 pathogenic variants that were then confirmed with Sanger sequencing. Although most had a history of cancer, none met the Amsterdam 2 criteria for Lynch syndrome. Only 1 patient had a first-degree relative with pancreatic cancer. The 2 available tumors from carriers of mutations in the mismatch repair genes were immunodeficient for their respective protein. 3.8% of probands carried a pathogenic mutation after accounting for the stratified sampling design. This corresponds to about 1 in 26 pancreatic cancer patients. 2% of probands had mutations in genes associated with breast cancer, and 1.4% in genes associated with colon cancer. The only characteristics significantly associated with mutation status were family and personal history of breast or colon cancer. The carrier rate in probands with colon or breast cancer in their personal history or in a first-degree relative was over 10%. Our study supports the use of multiple gene panels in pancreatic cancer, considering the breadth of mutations detected and the wide range of personal and family history of cancer in the mutation carriers. Our study also raises questions. Which pancreatic cancer patients should be referred for genetic screening? Do mutation carriers with atypical family histories of cancer face the same risk of cancer? Ongoing international collaborative sequencing efforts may provide answers to these challenging questions.